Can you hear me?
We can hear you.
Okay, good enough. Okay, well, good afternoon. I'm Dr. Eugene Harrington here at the Morehouse School of Medicine. I'm the co-project director for the HBCU Center for Excellence in Behavioral Health. And welcome to our April Behavioral Health Seminar, webinar. And we have a great speaker for you today. And I must say that this webinar is in cooperation and in partnership with the Southeastern Addiction Technology Transfer Center Network, SATTC, and the Southeastern Addiction Technology Transfer Center is located also here at Morehouse School of Medicine here in Atlanta, Georgia. The title of our workshop today, our webinar today, is Provider Readiness and where healthcare change meet business success. What a great title that we have for you today. And let me go ahead and say a little bit about the HBCU Center for Excellence. It is in cooperation with a cooperative agreement with the Substance Abuse and Mental Health Services Administration, known as SAMHSA, the Center for Substance Abuse Treatment, known as CSAT, and the Center for Mental Health Services, known as the MHS. And through these cooperative agreements, Morehouse School of Medicine established the HBCU Center for Excellence in Behavioral Health, funded through a grant number TI 023447. The goals for the Center for Excellence are to promote student behavioral health to positively impact student retention, to expand campus service capacity, including the provision of culturally appropriate behavioral health resources, and lastly, to facilitate best practices dissemination and behavioral health workforce development. A little bit about our speaker for today, Becky Vaughn. Becky has been working in the addiction field for over 30 years. She was a member of the founding board of the Georgia Association for the Prevention and Treatment of Substance Abuse, known as GAPTSA, in 1992, and became their first executive director in 1994. Her responsibilities include training and advocacy at the local, state, and national levels. In July of 2000, GAPTSA merged with an Atlanta coalition, creating the Georgia Council on Substance Abuse, where she served as president and CEO until 2007. Her work continues there as an advocate at the legislature and the catalyst in the community on issues related to prevention, treatment, recovery, homelessness, and drug court, with goals of reducing the impact of substance abuse on these Georgia communities. Her work includes passage of many bills addressing substance abuse disorder solutions, and as well as securing budget resources. Beginning in 2008, she took over the helm of the State Association of Addiction Services, SAAS, as their CEO after serving on its board since 2000. She has served on numerous state and federal committees and panels and speaks on the issues of a variety of settings. Becky received her degrees from the University of Georgia and Georgia State University. She grew up in Atlanta, but is enjoying the District of Columbia community as we speak, and also as a former teacher and mother of four, she's passionate about preventing and finding solutions to the far-reaching problems caused by untreated addiction. And with that introduction, we present you with Becky Vaughn. But Becky, before you come on, I think we need to take a quick roll call. And if those who are on the line, if you would just state your name and your school, we will certainly appreciate that.
Thank you so much, Dr. Harrington, and also Joan, Ms. Trent, for arranging for this. I'm always looking for fabulous ways like these to talk to people who are working in the field about what's going on and the changes that are coming and what that really means to those of us who work in this field. You just heard a whole lot more than you probably ever wanted to know about me, so you know a little bit about me. One of the downsides of doing webinars, the upside is I get to connect with a lot of people, but the downside is I can't see you and I can't learn very much about you. And if many of you have ever taken those public speaking classes where the teachers tell you just to picture your audience in their underwear so you won't be nervous, I actually picture my audience in a different way, and I think of you. I'm going to move on, hopefully, if this will work. Okay, that's a little about SAS. You know about that. I want to move on to how I picture you. I really do feel strongly that the people who work in our field very often are in thankless jobs. They don't realize what an impact they have with people, their families, and their communities, but you truly are the superheroes of your world. Many people are so sick and need so much help, and by you being willing to work them in whatever role you happen to play, it makes a huge difference, not only to the individual, but the family and the community and the state that you live in. So thank you from me for what you do. However, probably most of you actually feel like this. And working with providers all over the country, I know that's the case. And your brain probably feels like it can't take one more drop of information. So much has been crammed into it. It is absolutely full. But today I am going to try to cram a few more things into it regarding business practices, eligibility enrollment, some of the threats as a part of all of this new change, the opportunities that are out there, how we will talk about integration with mental illness and primary care services, parity and how that's impacting us, as well as some of the leadership models that we need to move forward. So we're trying to kind of think of us as moving from a social service agency more to a business that provides healthcare services. And that's a little bit different for us. And so if you look at a very simplistic model of business, we usually have an ordinary world. We have the vision of an improved world. And our business model, and I'm sorry you may not be able to see all those words at the bottom, but basically we are in a start position, and then we grow, we mature, and if it's left to its own devices, it traditionally declines. And since that's not what we want to do, instead, we take this new improved world, turn it into our new ordinary world, and keep the process going. In many ways, this is the way we talk to the people we serve who are trying to deal with the chronic disease of addiction. We ask them to picture themselves in where they are now, where they could be, and how they can keep moving in that direction. And then, instead of falling back, we ask them to take that position, look ahead, and see what they can do. So right now, the drivers of all of this change are three very big changes that have happened at the federal government. Parity legislation, which is making our services required to be on a par with all other healthcare services when it comes to insurance companies and benefits. The Affordable Care Act that Congress has passed, and many of the changes that come with that. And, of course, many changes in Medicaid. These are the big changes that are impacting what we're doing right now. So the Affordable Care Act had three very grand goals in that huge 1,000-page legislation. They wanted to reduce control cost of care, use resources more effectively, and so forth. They also wanted to, come on, let's see. Okay, I'm not sure what's happening. Anyway, we want to improve the health of the population and enhance the patient experience of care. Those are pretty lofty goals for one piece of legislation. So there are many moving parts to this in terms of how it was implemented. At the same time, when we look at the parity legislation, this is making it so that in people getting services, it'll be equal for days and visits, frequency, duration. No longer will they be able to say, oh, you can see your doctor as much as you want, but when it comes to behavioral health services, there's a limit of 15 visits. So those types of things will now be basically illegal. Equitable access, if they have in and out of network structures, and you'll be able to have that with behavioral health. No more of this fail first, which has happened a lot in our field, where a person's diagnosis actually indicates that they may need a higher level of care, but the insurance company says, no, we'll try them in this low-level outpatient first, and if that doesn't work, then we'll move them up. That's not done in any other piece of health care, and there's no reason why it should be done in ours. Fair copay so that you're not paying more in behavioral health. Inpatient, outpatient, emergency room, prescriptions, and utilization review cannot be any stricter than it is for other health services. So exactly what is the impact of all of this change on our field? More people will have insurance coverage. 70% of the people we treat now in the public system actually have jobs, and many of them actually have insurance coverage. But more often than not, it does not cover behavioral health services in a way that it should. So they end up in our publicly funded system because they can't do anything else. More demand for qualified and well-trained behavioral health professionals. At the same time, Medicaid and the states are going to play a bigger role in behavioral health, particularly in substance use disorder treatment. Medicaid has been used for a long time to fund treatment for mental illness, but not very much at all for substance use disorders. It has always been an optional thing that states could do or not do, and so as you can imagine, most states did not. And the idea is that there will be better coordination between primary care and specialty care, and our services fall into that specialty care arena. At the same time, there'll be a bigger emphasis on home and community-based services, increased priority on prevention. And that's not just prevention of substance use, but there's a big push on prevention of all diseases and promoting wellness. And this is something that is important to us because the better we do at this, the more healthcare costs will go down. And then a focus on the quality rather than just the quantity of care. Up until now, service providers have been paid really no matter how well they did. As a matter of fact, there was almost an incentive to not do so well because if the patient had to come back in, they could bill for them again. So now there's a big emphasis on quality. Basically what's going to happen is 32 million more Americans will be covered, either from commercial insurance, either through employer-sponsored insurance or insurance that they may have purchased off the marketplace, or because of expanded Medicaid. Medicaid is not expanded in every state. I believe we're up to 29 states now, but we feel like before the world ends, most states will have expanded Medicaid because there are just going to be too many issues for hospitals and everybody else where they will not have the funding. And of this 32 million, 6 to 10 million of those people will have mental and or substance use disorders. So the problem is we are in sort of a mismatched system that doesn't work very well with what is coming. Right now, about a third of our SUD providers and about a fifth of our mental health providers have no experience with third-party billing. With a bigger and bigger emphasis on insurance and Medicaid, our folks need to understand and have in place billing processes, and that's brand new for many of our providers. Less than half have a nationally certified electronic health record. As we move forward, you are not going to be able to bill insurance companies or Medicaid without an electronic health record. So this is another issue that many providers are having to deal with. Very few have working agreements with health centers, so the idea of trying to integrate with primary care is difficult. We're not there yet, and that's another arena that our providers need to be working in. And unfortunately, as they're wanting more and more highly qualified behavioral health staff, most of our providers do not have the required credentials to meet those demands. So what does the future look like? Basically, everybody's going to have a card, some kind of card that indicates how they get health care benefits, whether it's a card from an employer-sponsored insurance plan, whether it's a card that they bought insurance off the marketplace, as I said, or whether it's a Medicaid card. Everybody's going to have some way to finance benefits. So what? What does that mean for us? Basically, it means that we will be able to expand access. There will be many more paths for people to get to that health care because of these things. But more importantly, it will expand coverage. Like I said, so many of our folks have had insurance, but they just haven't had the benefits to get what they need. However, as we move forward, all new opportunities, people have these benefits, it's going to change a lot of the way we do business. One of the first ways is the way we finance our services. Right now, if you're working in the publicly funded system, the state office is your best friend. And it should be, because the majority of our funding comes from the federal block grant through the states, and then is combined with state appropriations and contracted out to service providers. And that's been the major funding source for SUD services, whether prevention, treatment, or recovery support. With this new arena, we are going to have to expand our circle of friends. We're going to have to be talking to insurance companies and managed care organizations, still working with our state and local agencies, but the other, besides Medicaid, we also have federally qualified health centers. These are big gorillas in our new world. Lots of money from the federal government is being pushed toward those. They are located in high-need areas. There's about 1,200 of them, and before probably 2020, there may be close to 2,000. And they are required to provide health services and behavioral health services. Many of them are not doing a very good job on the behavioral health side, and we're pushing them to partner with our community-based providers in order to provide good quality services. The other way it's no longer business as usual is in our workforce. We're going to need people with higher education, master's level licensed folks. At the same time, we need to do a better job of securing and identifying career ladders to get more people into our field, as well as being able to provide better wages and salaries to attract people and hold people in our field. At the same time, we now need more expertise because people are going to walk into our agencies and probably necessarily not have that insurance card that we talked about. Many of our folks are sick. They may have had insurance at one point but fell off, or maybe they didn't even know they were qualified to receive Medicaid. So we are the ones that are going to have to determine what they're eligible for and then get them enrolled. Because if we say, you know, you need to go get insurance or Medicaid, we all know how that works in our field. That's just an excuse for them to turn around and walk out. There are helpers, certified application counselors, navigators, and assisters to help us with that, and use federal online resources that also help us with that. And then the third way in our sort of simplistic plan is the whole world of technology. Right now there are fabulous things that can be done with smartphones. We can, as people are leaving treatment, we can load their identified trigger areas with the GPS system. Then let's say you one of our patients wanders into that trigger area, then a text message might pop up and say, what are you doing here? And then if they don't leave that trigger area, the next message might be in all capital letters, sort of the really and truly, what are you doing here? And then if the person still doesn't leave, then they might get a call from a sponsor, a peer support person, somebody that can really get in touch with them and say, what's going on? You identified this as a trigger area, and yet here you are. So amazing things that can help people navigate and also maintain their recovery. But at the same time, most of our providers can't think about that because they don't even have computers that can talk to each other. And it's hard to think about electronic health records and all the other technology when we're still way behind on that. So that's a big issue for us in terms of managing that. So right now we are considered specialty providers. We kind of operate separately, kind of like these spools of thread. And what we're going to be doing is integrating with, not into, but with primary and other chronic disease care. As you can see, we're not being sucked up into some big gray fabric. Our colors are all still there, but we're going to be working closely with everybody so that people will have better access. If they're coming in on the primary care side, doctors will be able to screen and see when they need our services. If they're coming in on our side, most of our folks do not have good primary care. The only access they have is to an emergency room. So access should improve. We should be looking at the whole person, which it only makes sense that if we're looking at the whole person instead of pieces of the person, we will ultimately get better outcomes. And that's what this is all about, better outcomes. So what does it look like when I talk about integration of care? Right now, we sort of operate separately. Primary care is in one building, community behavioral health organizations are in another community, and if we need each other, we just sort of do a little referral process. It's coordinated. There's a little bit of communication, mostly around logistics, did they make it to the appointment and that kind of thing, and just kind of some basic collaboration. And as we know in our field, if you give people a chance to get lost between our building and somebody else's building, there's a good chance they'll get lost. So it's not ideal. It's better than nothing, but not ideal. The next way, in sort of a basic model, is what we call a co-located, where the physical proximity is there. We are still two separate organizations. We each have our own billing systems, our own electronic health record, but we may be across a parking lot from each other, or we might even be in different wings of the same building. This does help because we end up with closer collaboration, not as many opportunities for people to get lost, and so ideally we're getting there in terms of making sure people get all the services they need in a way that each party is informed. The third way is where we actually merge all the services into a full integration model. Now, it's not quite as easy as it was for me to just move my little cartoon on top of the other one. It's a full practice change, full collaboration, and the ones that have done this, it takes time, but we have some really nice models around the country where this has happened. The great resource for all of this integration is the SAMHSA-HRSA Center for Integrated Health Solutions. It is right now housed at the National Council for Behavioral Health, and there is the website, integration.samhsa.gov. There are two particular documents that I'd like you to look at. One is focused on addiction treatment, and it has different examples of real agencies and what they've done in these different models of integration. I served on the advisory committee. We had great providers sitting around our table talking about lessons learned and how they did this and what worked and what didn't work. The other document that's there is called a standard framework for levels of care, and it goes into much more detail than my three little cartoon models, and also gives you checklists and helpful hints in terms of actually moving forward in your own integration. So we know the demand has increased even before all of these things came about, but all of these things are adding to that. We actually haven't gotten rid of stigma, but stigma has reduced over the years. We have lots of surveys that now show people understand that this is disease and they think people should have access to services. We have more payers that are paying for these services now. Medicaid expanding is obviously going to greatly increase demand. And the essential health benefits. These are being defined by every state, but they all have to include substance use disorder treatment and mental illness treatment. At the same time, I don't need to tell you, you just have to pick up a newspaper to understand what's going on with returning veterans and their needs in this field. So demand is greatly increased in that arena. We're trying to help the Veterans Administration partner with more of our providers so that they can meet this demand. And we're doing a better job of earlier and more accurate diagnosis. Our friends in the mental health field are beginning to understand that they shouldn't diagnose and put a mental illness diagnosis on people when they haven't even detoxed yet. And so many of these things, these psychosis, look like that, but then it turns out that many of them have just come on as a result of extreme addiction. And then at the same time, the Affordable Care Act, the ACA, obviously has had a big impact on demand. The other thing that's changing is we've pretty much been different systems, one sort of the public providers and one sort of the private providers, you know, the Betty Ford clinics of the world, and we haven't had much interaction. But that line between us is fading out fast, all in the name of capacity. We've got to all be working together to make sure we can meet this demand. And we're all going to be looking at the same payers in terms of insurance companies and Medicaid. And so we will basically all be working to make sure that people can get services. No doubt, we know there are plenty of people out there, over 23 million according to our last census from SAMHSA, that need substance use disorder services. But if all of this demand creates a void, then someone will step in and fill it. That's just the way it works. And the insurance companies won't necessarily be knocking on our doors saying, come be part of our network. Instead, there'll be plenty of people just raising their hands and saying, hey, I've got a master's, I've got a license, I can help you out. And yet we all know that many of those folks who have masters and licenses don't necessarily have any training at all in substance use disorders. So one of the reasons I am doing these kinds of presentations and traveling all over the country working with providers is because I want our good, skilled clinical providers to be the ones that are still providing services in this new environment. I want the folks who know what they're doing, that have stayed up on best practices, to be the ones. And so if we're not ready, we won't be the ones. It'll be other people stepping in and saying, sure, I can do it, even though we know they don't necessarily have the substance use disorder skills. So what's all the hoopla about? Basically, it's money. That doesn't probably surprise anybody on this call. Back in 2003, we spent about $121 billion on behavioral health services. The projection for this year is $239 billion. That's a little more than just a cost of living increase. Extreme increase, because in our field, we have been the least covered by all these services. So therefore, we have the largest projection of growth because of the fact that up until now, we've only been able to penetrate about 10%. And if any other disease was only getting about 10% of the people who had their disease into services, people would be screaming bloody murder. But that has not been the case with us, so we have a long way to go. And equity companies are seeing that this is a great place to invest, buy up providers, fire all their folks, bring in their own folks, and collect money. Hospitals who got out of our field a long time ago when the 30-day insurance money went away, they're suddenly saying, oh my goodness, I can get back into this field, and many of them are. Some of them have empty wings. Also, they're already equipped to bill and do all of these things. So there's a lot of money to be made. Again, the reason I'm doing this is because when I talk to the providers across the country and they hear that there's a way for them to get more money, they don't see it necessarily as getting rich. What they see is, oh my gosh, that means I can serve more people, because that's the mission of the people, of the providers that we have. So one of the problems is our folks being social service agencies and thinking of themselves as being public dollars, they've always been very adverse to risk. And that's the way they've operated. Not a bad thing. But what I'm now telling you is that I need you to think about risk. I need you to be looking at new opportunities and trying new things, because basically the Affordable Care Act is one big experiment. And if you avoid all risk, that is probably your biggest risk at not being able to be a part of this coming system. So, at the same time, when we talk about outcomes, we also have to talk about how are we going to measure that. And that's been tough in our field for a long time. But an insurance company is not going to reimburse you when you tell them that this patient is better because I had a conversation with them. They're going to want to see some measures. And we have some good screening tools and assessment tools that we can use to show progress. Because in the end, if we don't measure what we're doing, then we really can't manage it, and therefore we won't be able to improve it. And granted, the doctor that's working with hypertension has a very easy way to measure, but it doesn't mean that we can't do it too, because in the end, if we don't, we won't be paid for it. And that's the risk that we need to avoid. We want to get paid for what we're doing. At the same time, we want to make sure we're in compliance so that we keep the money that we bill for. So very simply, we sort of divided our providers, and in many ways, when I talk to providers across the country, they sort of divide their staff into these kind of three categories. The first one is what we call the early adopters. They have been watching the landscape planning, and they are in pretty good shape to be a part of this new system. Some of them very quietly, some of them you don't even know about. And you've probably got staff within your organization, or you can think about people you know, depending on what role you are doing, that are eager and ready to go, that this is exciting to them. Unfortunately, we've also got providers, and many of our providers have staff that are taking this attitude. They want it to go away. They call me and say, Becky, you've got to get rid of this stuff. And I'm like, you want me to stop healthcare reform? I'm flattered, but that's not what we want to do. These are where we should be. Unfortunately, most of our providers sort of fall in this middle category. They don't have their head in the sand. They know something's coming, but it is overwhelming and blinding, and it sort of immobilizes them. And I am committed to intervening, and we must, because if we don't, these providers are going to get run over, and we'll lose them in our system. It's not the time to be walking a road alone, as this deer is doing. We need to be working together to move forward. So our concern led to the development of assessment to kind of see where our folks were in the business arena. So we surveyed clinical and human resources, although not very many clinical resources. We feel like folks know what they're doing clinically. We're trying to help them from the business perspective. General management, finance, marketing, and health information technology. And I'll just show you a few of the results to give you an idea. One thing we found is the majority of our providers have budgets of less than $5 million. That may sound like a lot of money, but in actuality, it's kind of like having a $2 bill in your pocket. It won't take you very far. The economy of scale that's necessary to implement billing processes and HIT just will not work with that small of a budget. So we encourage people to either look at mergers or very legal networks where people are working together and sharing the expenses of those types of business activities. This is what most of our records look like today. They've worked fine, nothing wrong with it, but as I've already said, we have to have electronic health records. And you can see about not quite half of our providers are in the process, but we're concerned that even 11% checked the box that said we don't plan on adopting an EHR. And that's the wrong answer. It's just not going to fly. So the other clinical area that we're concerned about, because it crosses into the business arena, is the idea of providers not using medications to assist with treatment. You can see what we found out, and when we drilled down into over half of the providers that said none, there were three basic reasons. One, they didn't have the funding to do it. Two, they didn't have access to a prescriber, which is also a problem. But the third reason is because it didn't go along with the philosophy of treatment for them. And that is something that's going to have to change. There's too much research. Insurance companies understand it. Everybody knows that there's no reason not to use these medications to help people get into recovery. It'd be like telling someone who is trying to stop smoking, they can't use the patch. They just got to do it on their own. And so we're trying to explain to folks that this is a business issue. You won't be able to get into networks. You won't be able to be part of those things if you say you will deny patients medication. Doesn't mean everybody's got to have them. They still have to be used appropriately, but you won't be able to say it doesn't fit with our treatment philosophy. We also know that our folks don't know how to really negotiate contracts. Basically, they do whatever the state tells them to do, and that's not negotiating a contract. So we did find some that felt pretty secure when it came to negotiating a contract, but the majority of our folks said, no, I really don't know how to do this. This is what a bill looks like, and most of our providers do not understand billing codes and that kind of thing because they've never had to use it. It's not that they should feel bad about not knowing it. They haven't needed it. But these are basic billing codes that are used in Medicaid, and as you can see, over half of our respondents didn't know what we were talking about. At the same time, marketing, our folks don't know anything about marketing. They're barely able to keep up with who shows up at their door. It hasn't even occurred to them. So you can see most of our folks do not have a marketing plan, and some of these folks even thought that a website was a marketing plan. And so we're doing more to try to help them understand that they've got to market to referral sources, which many of our folks already do, but they've also got to market to individuals who are making choices about where to get their services and to payers, insurance companies, managed care organizations, so that they can be part of their network. So that's a whole new business world for most of our folks. And then we asked at the end of each section, do you feel like you need some technical assistance in this arena? And the dark blue is yes, the medium blue is maybe, and the light blue is no. And just to give you an idea, no provider, we didn't have a single provider check no all the way across all areas. And we had a lot of providers check yes all the way across all those areas. So we took this information to SAMHSA and said, hey, our providers need help or we're going to lose them. And out of that came BH Business, which is a fully funded product that helps providers with strategic business planning, third-party billing and compliance, third-party contract negotiation, patient eligibility and enrollment, and health information technology, all those things that we saw our folks didn't have. We used that TA to define it, and we are now in the second year of this, and as we go into the third year, we're even adding more courses. But we put together learning networks, and they are supported with a coach, with content experts, and some fabulous on-demand instruction and resources that are right online. Very briefly, topic strategic business planning. It's divided into two parts, and you'll end up with a strategic business plan. Contract negotiation is also divided into two parts where it'll help you figure out how to cost your services. Most of our folks don't know what it actually costs to provide a unit of service, and then how to negotiate a contract, and you'll end up with an agency contract. Billing, you'll end up with, I'm sorry, you can't see it, a third-party billing. If you already have one, we'll help you strengthen and make better use of it. If you don't, we'll help you implement it within your own agency. Again, the electronic health records, we want you to end up with a fully implemented EHR if you choose to work in one of these learning networks. We're just now adding mergers and acquisitions so that our folks can end up with a due diligence list to know what to look like, either if they are being acquired and they want to make sure they're getting the best deal possible, or if they're looking at merging with someone else. So that's another learning network. The eligibility enrollment, we want to help you change your intake process so that you can take advantage of all the resources to determine who's eligible for what and how to get them enrolled. We have a fabulous team that has put this together. Besides staff, my organization, we lead it, but we have partners of NIATEC, the National Council for Behavioral Health, and Advocates for Human Potential. We all work together to establish these learning networks and then provide the coaches. We have a team of people who actually design all the instructions, who are content experts, our coaches, and our conveners who get everybody together and keep everybody moving forward. And then, of course, our participating organizations, they are the ones who make this successful. they're the ones leading their organization to prepare for all of these changes. It's just basically a simple process. We have a website, bhbusiness.org. It's our kind of front door, and I don't know why that's not showing up, but anyway, it is where the application is and resources, and then our learning management system, which is where it's all password protected and where you can access all the resources so you can come in and out at your convenience. You can have other people working with you. And as I said, the very best part of all of this is it is fully funded by SAMHSA, so there's no cost to the agencies who are working in these learning networks. Again, bhbusiness.org. There's no www. I don't know why there's no www, but there's not. But check us out. It's a fabulous project to help people with these business things. So far, we've had 61 networks. You can see all across the country. Some of them are state networks, regional networks. Some of them are nationwide networks where individual providers just applied and we put them together with other providers who wanted to work on that same topic. So, in sort of closing, I want to inspire you. Transformation is not new. Many businesses have been doing it for a long time. Even the tobacco industry, we worked hard to reduce the demand for tobacco in this country. But they just transform themselves with all kinds of markets overseas. And if you don't think they're watching the marijuana process going on, then I think you'll be surprised because, after all, they do know lots of things about rolling topics. At the same time, we haven't had much experience with change in our field. Really and truly, and I think none of you will remember this because I'm figuring most of you are younger than me, but back in the 70s, we had all kinds of hoopla when we actually tried to combine alcohol treatment and drug treatment. People were saying you can't put addicts in the same group with an alcoholic. And, of course, we got through that. We understood it. But that was a long time ago, and we really haven't had much change since then. And I'm convinced that as difficult as that was way back then, that eventually when we get to the point where we're fully integrated and people are getting services as part of their entire healthcare system, we'll have new people coming into our field and they'll be the same way, like, what? You mean it hasn't always been like this? You mean y'all used to do it separately? And this will look just as silly as now the idea of alcohol and drug treatment not being able together. We have 3 leadership models that we're now looking at. We have lots of what we call manager leaders that are very focused on complexity. Boy, they know how to put out fires, organize, coordinate. We have what we call some leaders who are very focused on change, setting direction, aligning, and motivating people. We don't have many what we call entrepreneur leaders, where they're really focused on opportunities to identify, innovate, value creation, value taking risks. And as you can see, very few people fall into all 3 areas. And I want you to be thinking that way. Think about who that you work with actually have that lemonade stand. They're your entrepreneur people. They're the ones that have always looked for opportunities and ways to get ahead. And you want to make use of those people. After all, we're the folks that have always found a way to put square pegs in round holes. And it's mostly because nobody ever gave us a round peg. We've always had to make do with what we had. And we've managed. But if our desk looks like this, where we're doing nothing ventured and for sure nothing gained, we won't have a desk in another year. So we have to be willing to move ahead. I want to remind you how valuable you are. When you look at a chart like this and see that before somebody went into treatment, their health care costs, not their addiction costs, just their regular health care costs, over $400. And then just 12 months into treatment, their health care costs came down by more than half. And so what we've got in the integrated care, even in usual care, it still came down. So we have to convince insurance companies and managed care organizations that if they really want to reduce health care costs, then they'll get people into appropriate treatment. Look at these. Look at the people who green are in the throes of addiction and then the controls who are not in addiction, and how many more disorders they have in terms of people. And again, these are things that are just in addition to the things that are going on with their addiction. So we are valuable. We can help solve the problem of high healthcare costs if we can just get people into treatment. So this is my favorite dog. Well, I always say we have a tendency to just go after the one stick that's thrown for us, and I want you to be willing to go after all the sticks and even the ball, because I don't want anybody, after all this is over, to wake up and wonder what happened. I want everybody prepared, ready to go, ready to serve even more people, expanding their business, offering even more services, because what we do is applicable to so many things. So no morning afters for any of our folks at all. No whining. If you need to whine, go in a closet. I even have this sign up because we need to move forward. There are great strategies out there that we're happy to help you with. This is what we're focused on, whether it means doing the readiness and capabilities assessment, whether it means helping you get into BH Business, learning networks, whether it means helping you strengthen or establish a provider association in your state, or whether you need help in getting more training and more technical assistance. These are the strategies that we know work for getting people up to speed on business, and that's what we are focused on right now. There's my information, my contact information, and I did that pretty quickly, and even for an old Georgia girl, I talked faster than normal because I wanted to get it all in, and I'm now happy to take questions or comments or anything else you want to throw at me.
Well, Becky, thank you very much. This is Joan Trenigan. Dr. Harrington, if you want to open the line up, I just unmuted the lines, I do believe, but if you are interested, anyone on the call participating in the webinar would like to ask questions, this is the time for that. If you have any comments, please share. By pressing *6, you should be able to unmute your line if we don't hear you. Dr. Harrington?
Yes, I'm here. I unmuted my line. We, as Becky mentioned, we're ready to take any questions from the audience at this time.
I know sometimes a lot of this information is just so overwhelming, people are kind of like, not sure even what to ask, and we understand that too. That's why I always want to make sure that people have contact information if there are things that come up later.
I do have a question, Dr. Harrington, if that's okay. This is Lisa Black with SATTC.
Hello, Lisa. Go right ahead.
Hello. Great presentation, Becky. Thank you so much for the timely information. Concerning BH Business, are those e-learning opportunities and is the learning material actually archived?
Yes, it's all available. Right now, the goal is to get it all in a format that people could do individually, but right now it's only set up for a learning network to work with it, and it's designed to work with a coach and, say, 12 to 15 providers who form a learning network. But there's a lot of resources even on just the homepage of BH Business, even if you're not in a learning network. But bhbusiness.org can also show you how to apply and be part of one of these learning networks. The material is just not right now set up to absolutely do on your own. You really need to be part of that network and working with a coach.
Very good. Thank you so much, Becky.
And Becky, this is Dr. Harrington. What's the length of the training again?
Yeah, it does vary by topic. The ones that we've divided into two sections, one section usually takes about 3 to 4 months. We estimate, every provider kind of does it at their own pace, but we estimate that's what it takes, and that's how long they would have access to the coach. And then some of them, the eligibility and enrollment, it only takes about 4 months to get your process set up. If you're trying to do a whole billing system, that can sometimes take up to 6 months to get that done. So it just sort of depends on what you're trying to do. If you're working in the HIT arena and you're just trying to make better use of the electronic health record that you already have, that doesn't take as long as if you're actually trying to figure out how to choose one and get it started. But on average, they all last around 3 to 6 months, depending on how much you want to do. Our goal is not just to teach you. Our goal is for there to really be change at the agency level so that when you finish, you actually have something in hand, whether it is that strategic business plan or whether it is that new intake process. That's our goal, not just to be an online course. We want you to be smart, but we also want you to change some things.
Definitely, Becky. That's awesome. Dr. Harrington, this is Lisa again. You'll probably have to say hush up, Lisa. But if we have time, I do have one. Great. I have one more question. Becky, I'd love to hear you talk about the importance of collaboration as it relates to traditional modalities of treatment in addition to MAT treatment, medically assisted treatment providers, and the importance for that gap to be bridged and more education to take place in order for billing and just for everyone to be on the same page. What are your thoughts as it relates to continued billing for being able to continue with the education in regards to providing traditional providers with a fluid understanding of what MAT providers actually provide?
Sure. I mean, there's lots of ways to do it, and Lisa, you're right. This is one thing I love to talk about because, as I said, there's plenty of business for everybody. We don't need to be in a competition mode anymore. Instead, we need to be in a how can we do more with less, and that's where these networks come in because most of our agencies can't possibly afford to hire a marketing person, just for themselves, unless they're really big, and most of ours are not. Most of them can't afford to necessarily, hire a billing person and a contract person. So when they get together, and Iowa is a great example, almost all of their providers got together. It's a relatively small state. They all got together. They formed a network. They set up that IPO, that whole business center, so that then that center will be taking care of their business practices, billing and all of that. But then with the medication-assisted treatment, it can be that within that network, maybe not all the agencies are using medications, but within the network, if you've got somebody that needs that medication, then you get them into that provider. So it allows providers to kind of have a niche in what they're doing instead of trying to be, the jack of all trades, master of none. And so that people who are doing subacute non-hospital or residential treatment, they can focus on that instead of trying to say, oh, no insurance company is going to accept me unless I'm offering this and this and this and this. Where if you've got a network that's come together legally, then that whole network can go to the insurance company and say, we would like, as a network, to be part of your options. And the insurance company goes, great, only one contract, and yet look at all these services, that you're providing. So, and that gets right to, using medications, and then other types of, there's so many things we can do now, from acupuncture to medications. So there's so many ways that we can treat people now. We don't want to limit ourselves, and yet we can't do it all. So that network allows us to be able to make everything available to everybody. Does that kind of answer your question?
Awesome, Becky. Thank you so much.
Becky?
Yes.
I have one other question. Lisa and I are asking a lot of questions. But anyway, what are the minimal license levels that one professional needs to have to link into this network? And I pretty much probably know which behavioral health degrees that one would have.
Well, I wish I had that checklist for you so I could just tell you. It still does vary by state and by insurance company because of the fact that all that is regulated at the state level. In general, most of the insurance companies are wanting a master's level licensed person in one of the, counseling, in any of those type of degrees in order to be reimbursed for the highest level of treatment. Now, it doesn't mean there aren't other jobs within the agency that can also be reimbursed for, but as far as the highest level treatment, that's what they are looking for. Because for them, yes, they're about managing care, and yes, they're about managing costs, but in actuality, they're about managing risk. And the way they manage risk is to make sure that they have the highest educated people, even though we all know there's no research to indicate that they do a better job than somebody with 20 years experience and no license and master's. But what we're telling workforce folks now is you need that master's level license in your state to be the most valuable.
Okay, and we can get that information you said at the state level?
Yes. Well,
And
yeah. I mean, even Blue Cross Blue Shield isn't consistent because in one state they'll accept one thing and then in another state they don't. But yeah, it'll be through as the states begin to establish their essential health benefits and how they're doing it, and then what the insurance companies are going to do, then they will begin to be required to provide what they require in order to be part of their network.
is it possible for you to send just a general list to me via email? It doesn't have to be specific to any state, but I just want
just in terms of the scope of practice?
the scope of practice and the certification levels. I'm familiar with the degrees
Sure.
and all. That's no problem.
Yeah. Yeah. We have a federally designed scope of practice. It's really nothing but a template for states to look at because, again, this is all regulated at the state level. But sure, I'm happy to send that to you.
Oh, thank you so very much.
Hi, Becky. This is Joan. Dr. Harrington, I had a question, and my question is, Becky, we have a lot of students who are currently working, who are currently attending HBCUs across the country, and they're working towards entering the behavioral health workforce. What do you recommend that they can do, or their professors can do, or our counseling centers can do to better prepare and educate these students on provider readiness?
Well, the biggest way, a lot of our schools have really brought themselves up to require and provide a lot more coursework on substance use disorders, but many of them are still not requiring it. I spoke to a class not that long ago, and they were all master's level social workers getting ready to graduate, and they hadn't had any coursework on addiction. And frankly, I can't think of a single field they could go into that's not going to be impacted by addiction. They need it. So we're pushing all of our schools, and like I say, a lot of them have really risen to this push and are providing that. But we're pushing everybody to understand that in the social work, in the counseling, in the psychology, even in the medical field, people have got to have the appropriate level of education in terms of how to treat substance use disorders. And SAMHSA, has great tips and taps on the whole thing, but we just need to, and we need students to understand that if they are in a program that doesn't require it, oh golly gee, go get that course as one of your electives, because you will be so much more valuable when you go to get hired if you've got that background.
Okay, thank you, Becky. Well, Dr. Harrington, I'm going to turn it back over to you for our closing.
All right. Well, we definitely want to thank Becky again for providing that most valuable, fresh and new information. And we definitely appreciate you. And for those persons who are on the line who would like to get in touch with us about reviewing this information again, you can do that at a telephone number, which is 1-866-988-4228, or you can visit our website, which is www.hbcucfe.net. And that's on the screen as we speak, and Joan, and my information is up as well. So again, Becky, thank you so much, and thank all of you who were on the call today and were participating. And
yes, my pleasure, and really a shout out to those people who took the time to be part of this. You're already my early adopters just by the indication you want to know more about this, so thank you.
All right. Thank you.
Thank you.
Doing a debriefing?
Yes, Becky, don't hang up.